Thanks very much, Diana, and congratulations to you, the John Ritter Foundation, and GATA Canada for hosting this fantastic event. It is a true privilege to be with you here today. You have just heard from Dr. Eagle what is an aortic dissection, and from Dr. Milowitz what causes it. In the next 15 minutes or so, I will be speaking about how we treat acute type A dissection. As we know, type A dissection comes in two forms. It can be a DeBakey type 1 dissection, where the entire aorta from the ascending to the abdominal aorta is dissected. That's the most common form. Or it can be a type 2 dissection, which is limited to the ascending aorta. Both of these require an immediate operation. Unlike type B dissections, which can often be managed medically, type A dissection requires immediate surgery to prevent life-threatening complications, namely stroke, aortic rupture, or a heart attack. And we must remember that blood flow to all of the organs may be compromised during a dissection, which is why dissection is hard to diagnose and why the surgeon has to think about all parts of the body when planning their operation. So which parts of the aorta do we repair at the time of surgery for an acute type A dissection? Well, all of these surgeries require a median sternotomy, open heart surgery with the heart-lung machine. We always replace the ascending aorta, and sometimes we also have to replace the aortic root or the aortic arch. And we'll be speaking a little bit about why we do this in a few minutes. The minimal repair for a type A dissection is replacement of the ascending aorta with a Dacron graft and resuspension of the aortic valve. This requires open heart surgery, cardiopulmonary bypass, the use of the heart-lung machine. We also use hypothermia or cooling of the body to protect the brain and the vital organs. This is the most common operation for an acute type A dissection and is done in every cardiac center. However, patients with genetic conditions often have aneurysms of the aortic root. Unlike a type B dissection that can occur, often does occur in a normal-sized aorta, at the time of surgery for an acute type A dissection, especially in patients with genetic conditions, we often find an aneurysm of the aortic root that also has to be addressed. So if we have an aneurysm of the aortic root or the root itself is extensively destroyed by the dissection, then we must replace the aortic root, and we have two options: either a valve-sparing root replacement where the aortic valve is preserved, or what's called a Bentall procedure where the root is replaced with an artificial valve that is connected to a Dacron graft. There are two types of valve-sparing root procedures: the reimplantation technique that was pioneered by my mentor, Dr. Tyrone David, and the remodeling technique that was pioneered by Dr. Yacoub. For patients with genetic conditions, we suggest that the reimplantation technique is better suited for these patients. And this is what reimplantation of the aortic valve looks like. The entire aortic root is dissected circumferentially. All of the aortic tissue is removed. The valve itself is reimplanted inside a Dacron graft, and the coronary arteries are reimplanted inside the Dacron graft. It is important to note that this operation is technically complex and is only done by expert aortic surgeons. Even then, in the setting of an acute type A dissection, it may not be possible or safe to do this operation. The alternative is what's called a Bentall procedure, where the root is replaced with a prosthetic valve that is connected to a graft. The two options for the valve are either a mechanical valve or a tissue valve. Both have pros and cons, namely that the mechanical valve, although it's a durable option, requires lifelong treatment with a blood thinner to have that mechanical valve. The tissue valve, alternatively, does not require a blood thinner. It's easier to maintain. However, it's of limited durability, especially in young patients. Age and the overall health of the patient are the two most important factors when we decide what kind of valve to use in this operation. So those are the options for the aortic root. Now, what about the aortic arch? Now, some patients may require a more extensive arch operation than the standard hemiarch that we spoke about initially, standard replacement of the ascending aorta and just the undersurface of the arch, which is what is typically done, as you can see here. Now, patients who have a large aneurysm of the arch or extensive destruction of the arch, and sometimes those with distal malperfusion, meaning their distal organs are not receiving enough blood, they may require a more extensive operation of the arch. And so what are the options? Now, there are several options for extended arch repairs, including a hemi-arch with a stent graft that's placed inside the descending thoracic aorta under circulatory arrest. We can do a total arch replacement with a frozen elephant trunk, frozen meaning a stented elephant trunk that sits in the descending thoracic aorta, as is shown in the middle panel here. Or we can do a total arch replacement with a conventional elephant trunk, meaning the elephant trunk is made out of Dacron. Now, why do we use stent grafts in acute dissection? You will be hearing more about this from Dr. Chaloub, but essentially a stent can prop open the true lumen and restore blood flow to organs if there's a blood flow problem. We know that stent grafts are problematic in patients with genetic conditions, but they may be used in life-threatening emergencies. I will say that all of these techniques are generally only done by specialized aortic surgeons, and they are technically more complex. So similar to the valve-sparing route, extended arch techniques are also done mostly by aortic surgeons. So some patients who require a total arch replacement during an acute type A dissection may benefit from a frozen elephant trunk. And one technical point, although we generally do not recommend stent grafts in patients with hereditary conditions, in this particular configuration, the stent is actually sewn proximally to Dacron itself, and the arch vessels are reimplanted with Dacron. So this may in fact turn out to be suitable for patients with genetic conditions in certain situations with acute type A dissection. The jury is still out on this, but we are actively researching this area. So one very important point for you to remember is that with acute type A dissection, even after successful repair, we often have residual distal dissection that needs close monitoring. The aortic root may be unrepaired and may become aneurysmal in the future, and the arch and distal aorta are often dissected and may also become aneurysmal in the future. And this essentially means that anyone with any hereditary condition and anyone who has lived through successful repair of an acute type A dissection requires lifelong monitoring of the entire aorta, and that's a very important point. Final point that I would like to make is that certainly, although our surgeries for acute type A dissection have improved over time, our results have improved over time, timely elective surgery for an aortic aneurysm is life-saving. And of course, if we can have an elective operation, it's much better than during an emergency operation. We're much more likely to save the aortic valve. We're much more likely to not have residual disease distally, and our surgical results, including not just surgical mortality, but also the risk of complications, is much less if we can do this electively. So to summarize, acute type A dissection is a life-threatening condition that requires immediate surgery. The ascending aorta at minimum must be replaced. The majority of patients with genetic conditions also require a root replacement, and repair of the aortic root or the arch depend on many factors, patient factors, clinical presentation, and also the expertise of the surgeon. And often we are left with residual disease and we need lifelong monitoring of the entire aorta after repair of an acute type A dissection. I'd like to invite everybody to join us in Halifax, or either in Halifax or virtually next September 2021. This meeting is the Heritable Aortic Disorders Symposium. It'll be chaired by Dr. Gabby Horn in Halifax, and it is done in collaboration with GATA Canada and the Lois Steed Society of Canada. So it'd be great to see all of you there. And thank you very much for your attention. I'd be happy to answer any questions.